Similar to the approach that we've taken the last couple weeks, we're going to look at the mechanism of action of lithium, and then we're going to identify some of the evidence available regarding lithium's use for schizophrenia, and then we're going to look at some of the adverse effects associated with the use of lithium, which was not as significant as I had anticipated, to be completely honest with you. So lithium's an interesting drug. The mechanism of action is not completely understood. So there's a number of different actions that happen when patients are on lithium that they believe may play a role in the efficacy that we see for a number of different mental illnesses. So altering neurotransmission, so decreasing excitatory neurotransmission, specifically looking at dopamine and glutamate, enhancing inhibitory neurotransmission, primarily with GABA. It does have some interactions with norepinephrine and serotonin as well. It appears to alter secondary messenger signaling, and this happens for a number of different secondary messengers. So inositol, protein kinase C, intracellular calcium. And the thought is by altering the secondary messenger signaling, it may actually alter neurotransmission as a whole. And this may be one of the ways that it promotes cellular viability and decreases some of the excitotoxicity that may be seen with different conditions. There are other neuroprotective factors that have been associated with lithium's use, so an increase in antioxidant defense and an increase in brain-derived neurotrophic factor. There are some reports that it may actually play a role in increasing the neuronal tissue, potentially helping with new cell growth, or just preventing deterioration of some neuronal tissue and apoptosis overall. So a number of different ways that it may be involved. The primary place that we see it used is with bipolar disorder, but it's been investigated for the use in psychotic conditions from back into the 1970s. So there's quite a few reports along the way where this has been repeatedly attempted to being used for broader conditions other than just bipolar disorder. So what does it look like as far as efficacy is concerned? So we're going to look at a couple different things. First of all, most of the evidence that I'm going to summarize is from the Cochrane database review that was published in 2015. I have a copy of that for you. The specific trials themselves, they were a little bit harder to find this time, so I put in requests. I have some, but not all of them. But if you are interested in any one in particular, please just let me know. So first, I wanted to look at lithium as monotherapy, so using lithium alone as treatment for schizophrenia. So there were two sets of trials that were done. One looked at, lithium versus placebo. And what they found in these trials, so there were three of them. They were conducted in the mid to late 1970s into the early 1980s. They tended to use a few different efficacy endpoints, and they had relatively small sample sizes. So just for the record, the quality of the evidence wasn't incredibly robust. But they did not find a difference between lithium and placebo. And you can see that's the first set of numbers there with a relative risk of 0.83, but the interval went from 0.44 to 1.55. So this was primarily in a inpatient hospital population with patients who had been admitted for psychotic symptoms. There may have been some overlap with patients who may have had schizoaffective disorder or bipolar disorder that had a lot of psychotic symptoms, but they did not see a difference between the placebo and with lithium. They then looked at lithium versus antipsychotics. So there were a few other trials that looked at this. So they looked at lithium versus chlorpromazine in a couple trials, lithium versus flufenazine, and lithium versus pimozide. What they found was the antipsychotics had a significantly greater improvement in the brief psychiatric rating scale That's not a surprise. We would expect patients who are on antipsychotics to have their psychotic symptoms get better. There was not a significant difference seen in the lithium patients from baseline to endpoint. So these tended to be short-term trials, so between 3 and 8 weeks long. So even though the lithium group didn't look like their scores statistically significantly improved, there was no difference seen between lithium and antipsychotics for clinically significant response. So for the number of patients that had more than a 50% change where they would look like they were better, the lithium group and the antipsychotic group were thought to be, there was no difference between the two of them. So that was a little bit of a surprise, although there might have been quite a bit of variability within the lithium group, which is why just looking at lithium, their symptoms didn't improve statistically over the course of their trial, but there was no difference seen when we compared the lithium to the antipsychotics. There was a little bit of a signal that more patients in the lithium group did drop out of the trials. Only one trial reported reported reasons why the patients dropped out, and it was actually due to lack of efficacy and not due to tolerability. Excuse me. So take-home message, lithium as monotherapy, there's not evidence to support using it alone for the treatment of schizophrenia and psychosis. So now let's look at lithium as adjunctive therapy. So when the lithium is added on board to current antipsychotic therapy. There were 12 trials that were done. Patients in these trials tended to be in their mid to late 30s or early 40s. Most of them were inpatient, so they were hospitalized due to a mental health exacerbation. What they found was there was significant improvement in the patients who were randomized to receive the antipsychotic and lithium versus the antipsychotic and placebo. So the relative risk for clinically significant response was 1.81. And even when they dropped that threshold to see a 35% improvement in the brief psychiatric rating scale score, the lithium group was still significantly better than the placebo group with 1.77. And then just looking at both the BPRS and the PANSS individually, both of them showed that the lithium group had a significant improvement in symptoms compared to the placebo groups. The doses that were used. So in some of the trials, they went for a fixed dose of lithium. Most of the trials that were used in this particular meta-analysis with adjunctive therapy targeted serum concentration, so 0.8 to 1.2. A couple used 0.6 to 1.2. Some of the trials did have fixed doses of antipsychotics, so the patient was on an antipsychotic medication and that could not be changed when the lithium and placebo were added on board, although there were a couple of the trials where they allowed flexible dosing of the antipsychotics. So that does make it a little difficult to definitively say that the improvement was due to lithium alone. They used primarily first-generation agents, so haloperidol, pimozide, chlorpromazine, clozapine, and risperidone. There was one trial that was done in outpatients, and they actually added lithium on top of the flufenazine decanoate, so prolixin decanoate. They had relatively wide ranges. They were pretty aggressive in their antipsychotic dosing. So the chlorpromazine patients could be dosed up to 1,200 milligrams a day. The patients that were on clozapine were dosed, their average dose was about 450 milligrams, and risperidone was dosed at about 4 milligrams a day. So these were patients that were relatively ill enough to be in a hospital in most cases, and they were using pretty significant doses of their antipsychotic, but not receiving full response, and that was why the lithium was added on board. So there does look like there's a trend toward improvement with symptoms, But when they looked at relapses and the clinical global impression scales, there was no difference between the lithium group and the placebo group. So even though their symptoms got better, their CGI scores, looking like they were improved or very much improved, really didn't differentiate from the placebo group. There was also a trend toward more lithium discontinuations. Now, this wasn't statistically significant, but there was a suggestion that potentially tolerability may be a problem with lithium. So overall, lithium is adjunctive therapy. It does appear to be effective. When they looked at some of the subgroup analysis, those that had more of a schizoaffective diagnosis or those that had more effective symptoms had the most robust response. And I guess that's not necessarily a surprise. Excuse me, seeing that lithium is effective for the treatment of mood symptoms with bipolar disorder. There was also an indication that the strength of improvement seen with lithium was influenced by study design. So the bigger changes that they saw did tend to happen with more open label designs. So there was some concern that there is variability in how well the patients respond that is influenced by personal opinion, by the opinion of the investigators. What's interesting and a little bit inconsistent with that is that the CGI scores overall did not improve between the two groups. So potentially maybe there was a thought that lithium would help, but it really didn't help so much that it caused the investigators to robustly state that the patients on lithium looked much better or very much improved or very much improved. They also have suggested that there's another population that would respond very well, and that's the patients who are aggressive or may have violent outbursts. Now, the sample size for this was incredibly small. It was called out with a couple of examples in the trials themselves, but this has not been robustly evaluated, although that is a possibility for a patient population that could benefit with lithium. So it does look to be effective for adjunctive therapy when we add it on board to the antipsychotics, but now what about the adverse effects? So lithium does have a narrow therapeutic index, so we do need to worry about making sure that we're monitoring renal function, the patient's hydration status, as well as their lithium levels. The adverse effects were not well reported in most of the trials. Some of the older trials just said that it was well tolerated. It did look like there were some gastrointestinal complaints initially, so nausea, vomiting, diarrhea. It has an increase in polyuria and polydipsia. Although there are endocrine changes, so changes in parathyroid hormone, changes in thyroid function, these were not routinely evaluated in most of these trials. So it was really difficult to say to what extent that this occurred in these patients. They also were not likely on treatment for very long. The longest duration of any of these trials was only 1 year, and that may be something that we see past that. So there are definitely tolerability concerns. What's interesting is when lithium was added to the other antipsychotics, regardless of whether it was first or second generation, there was no significant increase reported in any of the adverse effects. So anticholinergic effects stayed consistent, cardiovascular effects were consistent, and most of the trials did evaluate for any type of arrhythmia, and they did not see a difference between the two groups. Most of the trials also evaluated for changes in movement disorders, and there was no difference between the placebo or the lithium groups when they were added to the existing antipsychotics. And there was no change seen in weight gain, although there was some suspicion that maybe patients who are on lithium would gain more weight, but that wasn't what they saw. So recognizing that they didn't have a clear increase in any of these adverse effects, but there has been, in some of the trials, more lithium patients dropping out than other patients, it is pretty important that we keep the tolerability piece in mind as patients are potentially started on lithium. So to wrap things up, Lithium is not found to be effective monotherapy, so it should not be used alone for the treatment of schizophrenia. Adjunctively, it does look to have a role, so it could be added to antipsychotics first or second generation. It may be more effective for patients that have some mood variability. It's unclear if it gives a definitive advantage in patients who are aggressive or have violent outbursts. It really was recommended that that be studied further. That may be a potential population for it. And that tolerability may be problematic. So making sure that we're checking in with the patients initially and recognizing that most of the evidence that we have is relatively short term. So we may not have to wait an extended period of time to see if this is effective. And we may want to be a little bit more conservative on the outpatient side with the dosing. For the patients that were on the inpatient side, they could be a little more aggressive with the dosing, and in some cases they were because they were being supervised at all times. So just something to keep in mind. So maybe it has a role. It does look like it has it has some efficacy to improve the symptoms, but chances are it's not going to be a solution for all of the patients that are not fully responding to antipsychotics.